My name is Jamie Dawson. I'm a nurse by trade. I'm a member of the Oregon Federation of Nurses and Health Professionals. And we, together with the Association of Western Pulp and Paper Workers and the Rural Organizing Project, are sponsoring this teach-in about the PPE crisis and what we can do about it. We have some plans. So I'll be the moderator, and I'm gonna get us started here. Thank you all for attending. A few housekeeping items. Number one, later in the event, we're gonna have breakout groups where small groups can have discussion. But until then, keep your microphone muted and your video off. That'll help us spare bandwidth, and this whole thing is going to work better. It's probably going to be, you're going to have the best experience if you use what's called the active speaker view. If you see some directly above where the talking head or heads are, you'll see some little tiny icons. One of them says show grid video, one of them says show thumbnail video, one of them says show active speaker video. Click that if you will. That'll show you the head of the person who is speaking at that moment, rather than like 100 tiny heads. You should be able to edit your name as it appears with your picture when your pic comes up. So do that if you care to. Do definitely please open up the chat now, and as soon as it's convenient for you, just type in a little something about yourself, so we all have some idea of who's participating. I'm going to frame the issues here just briefly to kind of set the stage for our panel. Probably everybody's aware that we're in the middle of an epidemic. In fact, the United States is worldwide the epicenter of the coronavirus epidemic. We have that unfortunate distinction. For the past couple of weeks, the US has consistently had better than 1,000 deaths per day. And the trend line looks like it's up. It looks as though we're sliding into the surge of patients that didn't happen on the West Coast in the springtime, did happen in New York City and a few other places in the US at that time. Hospital capacity is already overwhelmed on the Gulf Coast and in some other parts of the United States, and it seems likely that that is going to happen on the West Coast as well. We've all gone through a bunch of so-called social distancing measures, the lockdown measures everybody's familiar with. It's worth remembering that lockdown measures are a secondary control mechanism, and you only do lockdown if primary controls have failed. Primary controls would be quarantining sick people, doing contact tracing, and testing everybody that they've been in contact with, and if people are positive, quarantining them. That has been done successfully in some parts of the world. The initial outbreak in South Korea, for instance, was contained by those primary methods. But in the United States, none of those primary, more effective methods of containing the epidemic have been seriously tried. The corporations that run the hospitals and basically every single layer of government have failed. We don't, in the United States, have sufficient testing resources. Tests are being rationed. Public health authorities don't have the staff or the expertise to do the contact tracing that's necessary. And crucially for our teach-in today, we don't have the personal protective equipment that would be needed to keep healthcare workers and other folks who need to come into contact with sick people safe. for the duration. So it's a pretty dire situation. And of course, the impacts, the suffering, injury, death, and likely significant disability are concentrated in folks who are already at risk. So the poor, Black and brown people are suffering disproportionately. Basically, every single major institution in the United States, which some of us hoped would save us, all of those institutions have failed, and we are kind of left to our own devices. That's the bad news. The good news is that there are some things that we can do, and that's what this teaching is about. This teaching is an effort to dig into some of why we got into this bad situation and some of the things we can do to get ourselves out. Let me go over the agenda briefly. So we have a panel, and speakers from the panel are going to speak in this order. Kathy Gibbons is going to talk about what not having PPE means in the hospital. Mark Brenner is going to talk about the logistics revolution and lean supply chains in healthcare and elsewhere, and basically why we don't have the stuff we need, as well as some further dimensions of the epidemic. Greg Pallison is going to talk about how we can get PPE production started up, what that's going to take. Initially, we had planned to have a fourth panel member, Jess Campbell from the Rural Organizing Project here in Oregon. Unfortunately, she has taken ill at the last minute and can't be with us. Plan was that she would talk about, do some education about what it means to have a statewide political campaign, because that is definitely what it's going to take. And not all of us have done that. But we're hoping that some of those issues can arise during a question and answer period. After the speakers are over, we're going to break into small groups where you all can discuss with each other. And then we're going to put questions in front of the panelists. And then we're going to wrap up with some next steps. So our panel, first speaker again is Kathy Gibbons, who is a registered nurse first assist. For those of you who don't come from the healthcare world, that's a senior and extremely responsible position in the operating room. She's also a board member of both the Oregon Federation of Nurses and Health Professionals and also the Oregon Nurses Association. And she's here to talk briefly about what not having PPE means in the healthcare setting and for the rest of us. Kathy, take it away.
Thank you, Jamie. Good evening, everyone. Thank you for joining us. We're going to discuss a really important topic tonight. It touches everyone's life and it affects everyone. As you know, you don't have to be sick to be a carrier of COVID-19. My name, like Jamie was saying, is Kathy Gibbons. I'm a registered nurse, first assist. I work assisting in surgery with the surgeon. I'm a frontline healthcare worker. I'd like to point out that there are a lot of frontline workers, not just healthcare workers, that are affected by the lack of PPE. There are teachers, dental workers, many different frontline workers, people that are greeters when you come in to the clinics and the hospitals. We're all frontline workers. And regardless, we all equally are important and need proper PPE and equipment. Being on the front line without adequate PPE is a very frightening thing. I work in the operating room alongside a team assisting the surgeon with surgery. In my role, I'm usually at the bedside. Usually I'm assisting with the intubation. I'm usually the last person the people see before they fall asleep. I'm standing right above them, right overhead. And simply, just to let you know, we have many, many procedures where we have aerolization. These are fine mist and droplets. Our protective equipment that we're given to work with in the operating room are surgical masks, and those are not made or designed for fine mist or any kind of aerolization type of airborne fine particles. N95 masks are the preferred for this, any type of intubation procedure. Part of that is they are designed for small particles and fine mist, and also any kind of viral small particles. They also cover your face in a way that secures it adequately so that you don't breathe in these type of airborne particles. You know, at the end of the day, when I have been working on many cases and we've had a lot of intubations and extubations, and I'm really, it's kind of a frightening thing to go home and worry about whether I'm bringing a deadly virus to my family. They say that if we can just hold out for the vaccine, that this will all go away. But we know that that's not true. Right now, they're working on a COVID-19 vaccine, and shortly next month, going into September, into our flu season, we're going to be going into COVID 2020, and that's going to be a variation or a slightly different version of the flu that we have right now. So that, and the fact that there are various people that may or may not be vaccinated, they may decide not to have vaccines for any number of reasons. And so this is not going away. This is something that's here to stay. It's going to be a long, long process. So we really do need proper PPE for everyone to protect ourselves. I can't let you go before I give a few hints as a healthcare worker. Wear face masks, something that covers both your face and your nose. Make sure that you both are covered securely. Eye protection, wear some kind of glasses, sunglasses, goggles, face shield, and keep your distance as much as possible from other people, 6 feet plus. So, and by the way, face shields alone are not enough to protect you. You need to have a mask on too. This is anytime you're in public. So on that note, I am going to turn this over to Mark. And thank you for joining us again this evening.
Okay, thanks, Kathy. Can folks hear me?
Yes.
Fabulous. So I'm going to introduce the next speaker from the panel. Mark Brenner is currently I want to say lecturer at the University of Oregon's Labor Education and Research Center. Prior to that, for about 15 years, he worked at and was the sometime director of Labor Notes, which many of us would be familiar with. It's a magazine and also a organizing center, kind of the beating heart of the labor movement in North America. Mark's also an economist by training, and is here to tell us about modern supply chains, what's wrong with them, and why we don't have the stuff.
Well, thank you so much, Jamie, for having me. Thanks to everybody for being here tonight. One of the other things that I think is important to know about me as we get started talking about this really important topic is that I work both through the Labor Center and before I came to the Labor Center with a lot of different unions around the country. And one of the unions that I work extensively with for the last decade, pretty much, I've been working pretty extensively with the New York State Nurses Association. And so when the pandemic hit and everyone went into lockdown, I spent the first several months of the pandemic sort of as a full-time volunteer with the New York State Nurses. And I just want to stress, I feel like it's a very important thing for folks here in Oregon, where we have not been as hard hit by this pandemic, to really, I just cannot convey viscerally enough to you about how deadly this virus is and how devastating it can be, how quickly and how, the devastation can arrive. New York had its first documented case of COVID-19 on March 1st. And within a matter of 2 months, 3 months now, we have lost over 25,000 people to this virus in New York State. And it was just a unprecedented arrival of a pandemic. We've never seen anything like it. It really overwhelmed the hospital and the healthcare system. As Jamie said, it was really, showed a lot of the flaws, not just in our healthcare system, which we'll talk about in a minute, but also with the way that we procure and secure protective equipment. My job tonight is to talk to you a little bit about how that happens. And I'm going to get into that in a second. I just really want to stress sort of what Kathy was saying about, the risks to healthcare workers, to all of us, from this virus being airborne, as the latest science is really indicating the risk of airborne transmission is very high. That's why frontline essential workers absolutely need respirators, N95 respirators, or even higher levels of protection. And we're really here to talk about why that wasn't possible to secure first in New York, which was hardest hit early on by the virus, but now all over. I think it's 41 states now where the numbers are escalating, and we're seeing in Texas and Louisiana and Florida the same kind of overwhelm of the healthcare system that we saw in New York in March and April. Let me jump into what I'm here to talk to you about, which is the supply chain and how how we got into this mess and what we can do to get out of it. This graph I like to call, which one of these is not like the others? For those of you who are on the phone, I saw some of you are dialing in. I've got a picture up here looking at the number of cases since the first 30 confirmed cases were confirmed. That's like sort of your start point. Looking at the number of cases per million people in a couple of industrialized countries. I've got up here on the graph, you can't even probably notice it, but there's a line just sort of trailing around along the bottom. That's South Korea. Then you've got Italy, the United Kingdom, and France. And then the one that really stands out is the United States. Like, we are way up here off the charts. And so I really want to dive in with you about, well, how did this happen? As I mentioned, I've been working very closely with the New York State Nurses Association since the pandemic began. And I have a picture up here of a protest that we held. It was a speak out and a vigil that happened in the Bronx on April the 2nd, where nurses stood up and spoke out about the need for PPE. Their hospitals were not providing it. In fact, just weeks before, the CDC and the State Department of Health had lowered the guidelines that were being sort of relaxed, the standards that were being observed in the hospitals. For the healthcare professionals in the room, you all know this, but for those of you who aren't healthcare workers, normally in a situation like COVID-19, the precautionary principle is how we would deal with an unknown virus that's potentially airborne. We would maintain very high levels of respiratory protection, N95s, face shields, impermeable gowns, booties, head coverings, because we really don't know for certainty how this virus is spreading. We want at all costs to try and stop its spread. But because of the supply chain constraints, standards are being lowered consistently all over the country, starting with the federal CDC guideline, and then state departments of health were rolling back standards, as Kathy said, saying, oh, all you need is a surgical mask. Well, surgical masks don't filter out droplets, aerosolized droplets. They certainly can't protect you from those droplets that are suspended in the air for sometimes hours as infected folks pass by. And I think the other point that I really wanted to underscore that Kathy made is that what we're discovering now is that between 25 and 50% of people who are actually COVID positive are asymptomatic, so they're not showing signs. So that's why it's so important that you wear a mask when you're out in public, because you may be infected and not even know it. And that's what we call source control. That's protecting the world from you. And that is absolutely essential to slow and hopefully help us mitigate the spread of this virus. But it's absolutely not enough for frontline essential workers, whether they be in the grocery stores, whether they be working on the buses, in the transit system, and certainly not in a hospital that's being overrun with COVID-19. So this is April 2nd, this picture I got up here. 4 months later, where are we? Here we are. This is a headline from Business Week, Bloomberg Business Week, from July 31st. 4 months later, nurses plea for more PPE, and finally their pleas have led the US government to unlock 44 million N95 masks out of the federal emergency stockpile. So how is it after 4 months of knowing exactly what we need to protect frontline essential workers that we don't have what we need? And just to give you another picture of how bad the situation is, our sister union, the National Nurses United, released a survey on July 28th. They did a national survey of nurses. They found that 53% of nurses nationwide are reporting being forced to reuse N95 masks that are meant to really only be used once. 37% are reporting that they are reusing single-use surgical masks, and 54% are reporting that their employers are starting to utilize these unproven decontamination methods to clean single-use PPE. And I'll put some fact sheets and information in the chat as we get a little bit later along the program. But why is it that 4 months after this virus really overwhelmed New York City, that we are in a place where we're having history repeat itself all over the country? I'm going to talk about 2 reasons why that has happened. The first is our fragmented, profit-driven healthcare system. Basically, we, unlike every other industrialized country in the world, rely overwhelmingly on market forces to meet supply demand, to meet the need for supplies in the healthcare system. It's highly decentralized. Every hospital, every state government, every locality in a pandemic, therefore, is forced to compete with one another for PPE supplies. I've even heard nurses in Oregon talking about how PPE that was destined for your facility was diverted to other states that were harder hit than Oregon was. I certainly know that we're seeing that to this day. And, you know, the way I think about it is, you know, it's like a war between the states to try and get PPE, and a war between the hospitals to try to get PPE, because we're in this decentralized, profit-driven healthcare system. So just to capture what that looks like, I grabbed a couple of headlines that really speak to the crisis that we're in. The first one is from US News and World Report from April: states competing in global jungle for PPE. And then in May, the Wall Street Journal did a very extensive look at the PPE market. And the headline reads: "A chaotic gray market determines who gets coronavirus gear and who doesn't." This is one from a week ago in USA Today. "Rookie middlemen muddle the government's effort to buy coronavirus supplies." It talks about how people who've never been in the PPE business, much less the supply chain or logistics business, are now trying to make a quick buck off of the Health and Human Services and FEMA's efforts to try and respond, half-heartedly as it may be, to getting PPE to the front lines. The last headline that really grabs this free-for-all that we have in our healthcare supply chain. One federal agency was suing him for fraud. Another paid his company millions for masks. It really has been the Wild West, the PPE supply chain. We have hospitals that can afford it, chartering jets to fly to China, where a very large proportion of our N95 disposable single-use N95s were being made prior to the pandemic. We've got federal agents like commandeering supplies. I mean, it really sounds like a James Bond novel when you dive into it. But the result has been, and this is a headline from NBC News from a month ago, that few N95 masks, reused gowns, dire PPE shortages reveal COVID-19's racial divide. And that's the note I really wanted to end on, which is that this kind of market-driven, profit-driven, fragmented, decentralized healthcare system has really laid bare the inequalities, particularly the racial inequalities and the racial disparities in our healthcare system. Because think about it, which hospitals have the money to fly a private jet to China to try and get PPE? It is not hospitals taking care of working class folks, certainly not most communities of color. This is not where our community hospitals, certainly not rural hospitals, are going to be able to get their PPE. So we get whatever's left over, and folks are left in a position where they are absolutely not protected on the job. And I can say firsthand, from working with nurses in New York, that what happens in that case is that essential workers become vectors of of transmission for this virus. We have over 5,000 nurses in New York out of 42,000 who have filed workers' compensation claims because they've been exposed to the virus or fallen ill from the virus. In some of the hardest hit hospitals, as many as 25%. The nurses, and that's just by official hospital data, which is absolutely an undercount, of nurses got sick during the first COVID surge. In New York's nursing home community, between 25% and 33%, between a quarter and a third of nursing home workers got sick from this virus, all because they didn't have proper PPE. In Wuhan, China, after the government finally recognized that there was a real problem with this virus, they sent healthcare workers from around the country into Wuhan, and not a single healthcare worker that they sent in from outside of Wuhan not only did none of them die, none of them actually got sick from the virus because they were all equipped with the proper PPE. So we know how to keep people safe. The equipment itself is absolutely easy to manufacture, easy to produce, and we'll talk a little bit about how we do that in a minute. I want to talk now about the second reason that we've had so much trouble with our supply chain, and that is because our hospitals are operating following lean management principles. And, lean is something that for a lot of folks in manufacturing is old hat. So any of the folks who are the AWPPW members, I'm sure you've had your fair share of lean management programs coming into your plants. Definitely lean is a buzzword in the healthcare sector. And I want to talk to you just for a few more minutes about how lean has really made the problem of our supply chain, the vulnerability of our supply chain, so much worse. So just really quick for folks who don't know, what is lean healthcare? Lean healthcare is a system designed to eliminate waste through continuous improvement. Man, that sounds great. Who's in favor of waste? Nobody, right? Continuous improvement, like, don't we all want to be better? Don't we always want to, sort of strive, achieve, reach? Yeah, sure. But if you look at the kinds of things that hospital managers talk about when they say they want to eliminate waste, they say, oh, defects, overproduction. They don't want to eliminate overproduction. They make money off the tests that they make. The classic example that I always hear healthcare workers talk about is reorganizing the workspace. Like, oh, we're going to redesign it so you don't have to take so many steps to get to the lab, or so you're not waiting so long for your results. But critically, if you look at this slide that I've got up here, one of the things that you see hospitals talk a lot about wanting to get rid of is inventory. And that we'll come back to that in a minute. I just want to flag, spoiler alert, if you're a union, lean healthcare really comes at the kind of relationship that your union has with your employer. And I would recommend beware. Folks on this call can talk a lot more about what that looks like. But how does it play out? Lean healthcare is really about trying to identify problems in the system. This is a picture on the chart here from an actual a Toyota automobile manufacturing training manual. Lean healthcare really is adopted from manufacturing settings. It was really pioneered in Toyota. Some people even call it the Toyota production method. And the way it works, how do you identify the problems? In this picture, the problems are the rocks and they're underneath the surface. So how do we find them? In the picture, the water is the inventory. So how do we get to identify our problems and fix them? We've got to lower the inventory so that the problems are visible. And think about what that means in a healthcare setting. What is inventory that we're talking about getting rid of? It's exactly the things that we need. Critical PPE, ventilators, the ability, staff is another thing that we are often cutting. I'll skip through just for sake of time about what are all the ways that hospitals try and solve the problems once they identify them. But a critical one that I'll mention to you is just-in-time inventory controls. This is a way to make sure that instead of having all this inventory sitting around, that we can get it just when we need it. That I think that the ideal for a hospital executive is that basically right when you need something, somebody would put it in your hand, that it would never sit on a shelf. But in a kind of a pandemic, just in time absolutely decimates the kinds of things that we need just in case there's a big problem. So imagine that this guy here in this picture who's standing in front of all of these N95 stockpiles is a Kaiser accountant or a Kaiser chief financial officer. He'd have an aneurysm seeing all of this equipment sitting around. Same if he saw like this picture here, all of these ventilators. We're not making any money if nobody's on those ventilators. If he saw someone with a powered air purifying respirator, he'd be like, we don't have Ebola in Oregon. Why in the world would we want a PAPR? And the same with staffing, right? Why would we have enough people to have folks come in and help you out in the ICU? That's not making us any money. That's not how we're gonna pad the bottom line. And so all these things in a lean system have been eliminated and they've left us incredibly vulnerable to COVID-19. So I'll skip some advice for you about how they go through and try and refigure the relationship with the union. But I'll leave us with this point, 2 points I wanted to leave you with. The first is that the only way right now, given the fragmented and decentralized state versus state, hospital versus hospital supply chain system that's completely overrun with bad actors and scam artists, the only way that we can actually take care of frontline healthcare workers and other essential workers is to use the Defense Production Act to mobilize and marshal the resources that frontline essential workers need. And I'll also make a plug because I got the mic for a minute. That given the fact that so many people are out of work in this pandemic, unemployment rate is shooting up towards 20%. Millions, I believe the latest estimate is 43 million people are at risk of losing their employer-based health care. Now we could never be in a better position to make a case for and more in need of a healthcare system that puts people over profit. So as union activists, I encourage us all to talk a little bit more on this call and beyond after we get the Defense Production Act up and running to put Greg and the other paper workers back to work, that we need a real serious conversation about what Medicare for All single-payer healthcare system look like. Thanks for the time. Great to be here with you all, and I look forward to answering your questions.
Thanks, Mark. That was good and thorough. I see that we've had some people join since we did the housekeeping announcements at the beginning. Just to throw out there, if you've joined late or if you didn't say anything at the beginning, try getting on the chat and saying a little something about yourself so we'll know who's here. And I'll introduce our next panelist. So Greg Pallison is the national president of the Association of Western Pulp and Paper Workers, which for the healthcare workers on the call is a union, which enrolls folks who work at most of the paper mills in the northwestern United States, Oregon, Washington, Idaho, Northern California, and Greg's going to correct me if I'm wrong about this, I think also Montana. Now, why is a healthcare union getting together with a union of people who work in paper mills? So here's why. Early in this pandemic, when it became really clear to those of us in healthcare that our employers, even assuming they were operating with goodwill, which may or may not be the case, even assuming that, it became pretty clear that they couldn't really solve this PPE problem. So we at OFNHP reached out through Lurk's and Mark's help to the AWPPW with this question, which is, hey, N95 masks are made out of fiber. Do you guys have any shutdown plants or shutdown production lines that could be restarted to produce the personal protective equipment that we need? And Greg's going to tell you more about that because the answer is yes. And so, we've started a campaign to put pressure on the Oregon governor, Kate Brown, to do sort of a mini state level Defense Production Act, use emergency authority, since there's a state declared state of emergency, to mandate the reopening of the shuttered paper mill in Newburgh, which AWPPW has been trying to get started again since 2016. I'm not the expert on any of these things, so let's let Greg take it away here. Greg?
All right, thanks. So I just put on a mask, this mask, and I know I'm preaching to the choir on a lot of this. This mask is a woven material. Things pass through it easier. It's not as good as an N95 or as, the mask made in China, KN95s. So with regard to, the PPE that's required, currently, as I understand it, there's certainly a shortage of N95s and a shortage of gowns. I think it's mind-boggling. Here we are, as you heard Mark talk about and others, greatest nation on the face of the earth, and the most expensive healthcare on the planet, and our own providers, those who are frontline workers, cannot get the proper PPE. It makes your head hurt. Years ago, when I worked in the industry, I've been out full-time since 2003. I'd go through K95s myself, sometimes 5, 6 a day, depending on the situation and where we were working. So within the pulp and paper industry, there's different products that are made. Pulp, straight up, can be used to make masks that are very similar, pulp and paper products, very similar to the N95s. Think of, for instance, milk cartons. Milk cartons are made out of pulp paper material, but they use what's called an extruder, an extrusion. It's extra equipment that makes it so liquids don't go through it. So that type of equipment could be added to some of the mills in the Pacific Northwest to make the safety devices we need. We had spoken with the mill manager at the Georgia Pacific Mill in Toledo, Oregon. His guesstimate, without a real in-depth research into it, his guesstimate was that they could make some masks or make masks equivalent to the N95s with about a $20 million investment and 6 months time period to get the equipment installed. You know, think about it. If we would have had the mask, general public even would have had a lot of the masks available when all this first started, and a lot of people were wearing them, our economy probably would not have been shut down. So think of the cost, the trillions of dollars that it's cost us, all because in the sense of businesses are driven for profit. And so with regard to, for instance, the West Rock mill in Newburgh, Oregon, that mill had gone through various owners, came out of bankruptcy, a paper company called West Rock, and West Rock was a merger of paper companies. West Rock is the #2 US paper producer. They ended up buying Capstone, which is the old Longview Fiber, the #5 US producer. Right before that, they bought the mill in Newburgh, Oregon, and a mill in Ohio, and a mill in Dublin, Georgia, for a little over $288 million. West Rock, 1 week to the day after they became owners of those mills, they closed the mill in Newburgh and the mill in Ohio. You know, you think, what a terrible business decision. What they did was, the instant they announced closure, their stock shot up, they reduced the supply of product they sell, and it drives the price up. So virtually everything in the industry for years has been, you buy your competitors and you reduce supply. And so if you fast forward in a sense to now, we need all the safety equipment and we can't have it. We had discussions with Governor Brown's office prior to coronavirus with regard to trying to get the mill in Newburgh restarted. We had 2 potential buyers that were legitimate buyers, would have bought it. In fact, one of the buyers would buy it today if they could, still buy it today, and restart it and refurbish the equipment in there to make the products that are needed. West Rock refuses to sell it. We have internal correspondence from West Rock, internal emails that says they will not sell to anybody who's going to restart it, and the equipment has to be destroyed. And then we have a list of all the equipment needs to be destroyed, millions of dollars of equipment they want to destroy. That should be criminal. So, those mills could be restarted, retooled. The mill has been retooled a number of times to make different products, and that could certainly happen. And as I stated, for instance, the Georgia Pacific mill in Toledo, or other mills could retool. So we proposed to the governor. Of course, the governor says it's private business. She doesn't have much leverage. There's not much she could do. What we proposed was, well, be bold, exercise eminent domain, seize the mill, because for all intent and purposes, West Rock abandoned that mill. Seize it, pay West Rock market value for the mill, and restart it. And especially restart it now, making the proper face mask we need and the proper gowns that those in the medical profession need. And if you do that and become the supplier, especially for the Pacific Northwest, it'd be fantastic, especially with regard to all of our safety and health, that we're living in each day. We literally, so pulp and paper is considered critical infrastructure and industries. Our workforce, they're literally working elbow to elbow every day. They cannot maintain 6-foot distancing, hot, sweaty work. And, we're going to have an outbreak. And we have started to see that happen at some of our locations that had not had much coronavirus, COVID-19. We're starting to see that now at some of our locations. So what's part of the answer from our current government and administration? Lower the standards, as you've heard people talk about before. Instead of figuring out how to help us be safe, it's lower the standards. So OSHA lowers the standards. They lower the requirement of masks. And in effect, what that does is it gives credibility to, some people say, well, this whole thing's a farce because these masks don't do what they're supposed to do and they're lowering the standards. It really undercuts safety and health for all of us, which is shameful. So, Jamie, I'll pretty well end with that. I know we'll have questions in the breakout, but I want to emphasize the mills and the infrastructure that are there now can certainly retool to make the equipment we need, and that should be happening. Unfortunately, there is not the political will to do it, which is mind-boggling when you look at the cost of not doing it compared to if we actually did it.
Thanks, Greg. Getting the political will to happen is where we come in. Got a couple questions to start with. So I'll give the first one, because it's kind of a technical question, to Greg, which is, if I can find him here to get him started up again. So Greg, let's say we were successful and we managed to arm twist the governor hard enough that she developed some political courage and opened up this Newburgh mill, and you got your laid off members back to work, making some economic development, some small town jobs happen, and you started producing N95s. If you had that plant running full steam, how many masks could you make?
Yeah, good question. And unfortunately, I don't know the answer to that. Part of the, I think, somewhat difficulty is getting an employer or somebody in the business, they're asking the same things. How many masks can be made, and or how long, and what kind of market are they going to have? They don't want to do the investment and then end up having it being short term. So that would take, take some economic study, a little bit of research for it to get the answer to that.
Greg, give us round numbers. Like how many container loads a month do you think you could spit out of a plant like that?
Seriously, I don't know, but I suspect that what they could make on, there's 2 paper machines there, and if they put in the extruders, I firmly believe they could certainly make enough masks that would supply all of Oregon and Washington state on what's needed for the medical professions, that they could be wearing a mask and wear one mask when they go into a room, and when they come out, throw it away and put another one on.
Great. I'm gonna call on Shauna Ross from OpenHP's Peace Health Unit. Megan and Joshua, can you get her unmuted on video?
I'm unmuted.
Awesome. Fire away.
Our question that was raised was by Wes, but by everybody too, I have to read my notes now, is how can we support pushing Governor Brown into retooling and making masks and PPE? And with the way this virus is going, I mean, it's more than healthcare, it's education too. What can we do?
Mark, do you want to field that?
Well, I think that what I was saying in my small group is that I think there's really, we take this at 2 levels. First is at a really concrete level, I think that OFNHP members can be trying to schedule meetings with their state reps, state senators, state legislators to talk about this issue. As frontline healthcare workers, you bring a particular expertise and authority to the question and really push for local solutions to our PPE problem. I think that we have to get this idea in this demand in a wider circle of elected officials. And I think, pushing people who also can wax poetic about it, but can't actually do anything about it, like our senators, Jeff Merkley and Ron Wyden. I think that there's plenty of people at the federal level who don't actually have to take any political hit for this, who might be supportive of pushing for local jobs to create PPE for the region. But it really is going to take some, I think it's really a longer term campaign to build a political will for the governor to do that. I think that also another thing that I think is really important is to, as a union, to also talk to other unions. I mean, obviously the AWPPW is very interested in this, but this idea is probably not as widespread as it could be in the labor movement. We need more allies sort of behind the idea of solving this problem locally. And I think that only once we kind of build that level, and I would also add, and this is where we're really sad to be missing Jess Campbell from the Rural Organizing Project, talking to some of the hardest hit communities. Like I was talking with a nurse in Hermiston, Oregon, a couple weeks ago about an outbreak of COVID in a potato processing plant in Hermiston. And, you know, I think in some of these towns where they really have very little infrastructure, healthcare infrastructure for caring for COVID patients, there's a receptivity among local community-based organizations and groups that are working with essential workers, immigrant workers, farm workers, to really you know, talk about how this could also meet their needs, their community's needs. We need to build a bigger coalition of unions and community organizations talking about this, pushing for this. That's the only way we're going to get the governor to pay any attention to us. But I think, you know, we also can start by raising the issue with our the people who do represent us, our local legislators, local state senators. I also wanted to just make a plug for eminent domain is not something that is restricted to the governor's office. We certainly think we ought to be raising the issue with Yamhill County and other local officials in areas where we have idled mills, where there are potential jobs to be created. I know sometimes paper mills aren't always located in the political hotbeds of Oregon, at least not the progressive political hotbeds of the state. But it's definitely worth going at different levels of government as well.
Thanks, Mark. So I'm hearing coalition and you know, organize more widely to develop some leverage. Looks like Charlene Sales had a kind of a question about mask reuse. That maybe you can also field, Mark?
Sure. What's the question? I didn't see it.
Charlene, do you want to unmute yourself and fire away?
Well, one of my many questions was, we are having to reuse our masks well beyond the recommendations from the manufacturers. I mean, right now I'm using 5 masks that I'm supposed to use for 5 weeks. You know, 1 every Monday for 5 weeks, 1 every Tuesday for 5 weeks, and so on. That I keep stored in my locker where, you know, it's going to get, you know, my locker is this big. So it's going to get, you know, messed up. And after wearing a mask, has anyone ever fit tested someone after 50 hours of use to see if it's actually still working? You know, because essentially I would be wearing my mask for 50 hours over 5 weeks time, on and off, several times a day, in and out of my locker for several weeks. It's like, is it still functional, or is it really after, you know, 12 hours, it's like, okay, the seal's broken and it's not even doing you any good? I mean, does anyone actually test this to know, you know, what it does? Like, once it comes off your face, is it really effective to put it back on?
Absolutely. That is the major issue with extended use and reuse of just single-use PPE, is that it's absolutely not designed. I mean, even 3M, the largest global manufacturer of just single-use N95s, has refused to endorse the policy of reuse, because that's not, they're worried, I think, quite honestly, about being sued if they buckled to the pressures from the Trump administration to endorse this practice. You're absolutely correct. What happens immediately, I mean, anybody who's had to wear an N95, you know that the elastic attached to it wears out pretty quickly. The seal on your face can't be maintained. And that's the other problem. That's why they're not designed for being used like this. And that's why the hospital is putting you at risk every time they force you to do that. I know one of the things that one nurse group I work with has done is we filed OSHA complaints about that. We've done marches on the command center to try and force hospital administrators to provide more N95 access. We even filed a lawsuit in New York against the State Department of Health because of their relaxed standards. They were creating a transmission vector for healthcare workers and other essential workers. So those are all some of the things that you can do to try and force your employer to improve their standards. We also need to raise this issue with our legislators. And I just wanted to mention the problem gets even worse with decontamination. I know some places are trying to do this hydrogen peroxide vapor decontamination method. It completely erodes the elastic band. The mask just falls apart after 1 or 2 treatments, and so it's absolutely unsafe. They're putting your life at risk. We need to organize to stop it.
Another question, which I'm going to turf to Mark, came up in one of the small groups. Lynn Pearson from the Eugene Springfield Solidarity Network raised the experience that in nursing homes, SNFs that have had had COVID cases, that large portion of the staff, half the staff, either gets sick or hits the road because they're fearful they're not being provided with proper PPE. Are we in other places seeing similar kind of collapse of healthcare facilities due just simply to lack of staff? Is that something that we've had experience of recently?
I can really speak only to the New York experience, which I know real well, and I can tell you that there we had really, it was sort of the 2 extremes. You had places that were overrun with COVID, and where the hospitals were bringing in people from the National Guard. There were doctors from the Navy and other military personnel that were coming in and working in a lot of these hospitals. There were tons of travelers. And then in upstate New York, we had hospitals that were laying people off and furloughing people because they had suspended elective procedures. So rather than actually keep nursing and other healthcare professional staff at the ready for when there could be a potential surge in their communities, they were trying to save a buck. In terms of your question about nursing home staff just sort of picking up and hightailing it out, I haven't heard as many cases of that. I've heard much more of COVID hitting the staff and people being out sick. I know when COVID really peaked in New York, as I mentioned before, statewide, we had between 1/4 and 1/3 of the nursing home workforce testing positive for COVID. And since COVID was really concentrated in the greater New York City metro area, that really means that for the nursing home staff in that area, it was probably more like half of people were getting sick. So it's really been more about people falling ill to the virus. And as all of you have experienced, people are being mandated to keep working even if they've been exposed. As long as you're afebrile, for 2 days, go back, keep working. I mean, there's all kinds of dangerous things that employers are doing, making the problem worse.
And one final question, after which we're gonna do some wrap up here. But for Greg, should we succeed in reopening this plant in Newburgh, how many jobs are we talking about in that community?
Yeah, good question. If that mill reopened and retooled and with some expectation of additional automation, right at least 250 permanent jobs at the mill. And keep in mind, and there's been a number of studies that have verified, for every one of our pulp and paper jobs, permanent jobs, there are 7 other permanent jobs that are created by that. So, you think of all the equipment has to go in, the manufacturing of it, the maintenance of it, everything from, supplying raw materials and all that. So it's pretty extensive on the increase on employment. And then, the jobs created are good family wage jobs with good benefits. It's not minimum wage jobs or a little better than that. So it has a huge impact on every mill that is closed. The mills are the single largest tax provider in the areas where they are, even the Oregon City mill when it closed. So it has a huge economic impact on the communities.
Thanks, Greg. So we're close to time. It's probably time that we wrap. And I have the job of doing a little bit of summary. So clearly we need PPE. We have a project that, and we need real PPE, not pretend PPE. we have a project that has the potential to actually make that happen, which, as I said, is as we've discussed, is not going to be politically super easy, but you know, I believe that we can do this. It's technically feasible, and I think if we put it to the people, it's gonna find some support. So, you know, we have a chance to kind of kill two birds with one stone. One, you know, getting PPE is really going to mean the difference between life and death for our colleagues in healthcare and for other people as well. And on the other hand, you know, we're in a period of economic collapse worldwide and certainly in the United States. This project, you know, has a potential to address that. And then finally, to build some power for labor unions and for workers in general, which are going to be necessary to deal with all the crises that we're dealing with here, including the ecological crisis. In terms of next steps, well, excuse me, I'll go back a step. So that's politically a big lift. How are we going to make that happen? As has been discussed, we're going to need to broaden this coalition, you know, to medium-sized local unions is a really good start, but it's not necessarily going to get us all the way there. We're going to have to get some more friends. And we're going to have to, we've heard a lot of really compelling stories. There certainly were some in my breakout group. I'm betting there were in most others. We're going to have to really give voice to those stories and create some urgency around this. We're going to have to, our slide here says make noise. We're going to have to, you know, really publicize this in the community and then finally make trouble. We're going to have to disrupt business as usual because the Democrats who run things in this part of the world are not, you know, they don't have by themselves the impulse to help us. So that's the theory of the case. In terms of next steps, here's what we're asking. OFNHP has a committee internally, and any healthcare workers who are interested in joining that, we would love to incorporate you. We got several of the committee members. We heard from Shauna and Kathy. We have others, but we need more on that internal committee to make this campaign happen. If you're with a different organization, we would ask that you endorse this campaign, get your organization to endorse the campaign, do internal education. We have a sample union resolution, and we have thus far a little bit of other literature. We're hoping to develop some more that we can get to folks. So if you're part of an organization that's not one of the sponsors of this, we'd ask that you get your organization to sign on to this campaign. If you're in a leadership role in an organization, we are, we're trying to build a coalition. We're going to need to assemble a campaign committee. It's going to take a lot more folks than our fine two unions to make this happen. So we're assembling a campaign coordinating committee. So if there are folks who are in a leadership role in an organization, please sign up. If you don't fit any of those categories, but you want to do the work, you're feeling the fire about this and you want to do the work on this campaign, definitely let us know. And then finally, asking folks to join an email list, because we're going to try and stay in touch and coordinate action. If you want to sign up to do stuff, that could take a variety of forms. We need people to do research. We need people to do outreach. We need people to do direct action. You could just say so now in the chat. We're also going to be sending a follow-up email to everybody who is registered for this. which should give you an opportunity to write back. Okay, fabulous. I hope that was clear, folks. Thank you so much to all of our panelists. Thank you all for being here. We're signing out at 8 o'clock on the dot.
Thank you, Jamie. Thank you, everyone.